Frédéric, c'est toujours un plaisir de t'avoir avec nous. J'espère que ce sera un symposium exceptionnel comme toutes les choses que tu fais. C'est vraiment un honneur pour nous d'être avec nous. Et tu peux commencer quand tu veux.
Okay. Hello, everyone. Many thanks for the invitation. As you can see, we got the first snow in Switzerland. I don't know how it is in Greece, but I would have loved to see the sun from Greece, but now we have the snow of Switzerland. And it's a pleasure to talk to you about autofluorescence of the parathyroid gland and ICG perfusion angiography to help detect and protect the parathyroid glands. So I will give you a short background on hypopara. I'm sure you already had this before. Some principles on fluorescence, and the two main topics, one on autofluorescence and the second on ICG angiography for the detection of the perfusion of the parathyroid gland. Regarding hypoparathyroidism, as you probably know, the reported rates of hypoparathyroidism is quite low if you look at studies coming from specialized centers, between 0 to 3% for definitive hypoparathyroidism. But if you look at studies coming from registries, so population-based registries, it's more about 10%, which is much higher than expected and probably not really good for those often young and most often female patients. So almost 10% in the North American registry, 12% in the British registry, 6% in the Swedish or Scandinavian registry, and almost 10% in the German registry. So we are going to talk about autofluorescence of the parathyroid gland, so the possibilities of the characteristics of the parathyroid gland to emit a stronger autofluorescence signal as compared to thyroid gland, and to perfusion of the parathyroid gland. So here you see parathyroid gland after thyroidectomy, which is well perfused. What is fluorescence? When a substance is excited at the light at a given wavelength, one of these electrons gets in an excited state, here loses some energy and then goes back to its ground state, emitting another light with a lower energy, so higher wavelength. This is the principle of fluorescence, and this principle can happen in the UV light, in the visible light, or in the near-infrared light. If it happens in the UV light, you can make visible something that is not visible. So if you excite here in the UV light, then the substance will come in the visible light. For instance, here you have a UV laser that is exciting kinin that is autofluorescent, and you see that this kinin that is non-visible here gets blue by this excitation. So what about autofluorescence of the parathyroid gland? This was discovered about 10 years ago in Nashville, and they published the first study in 2011 showing that the fluorescence intensity of the parathyroid gland was 2 to 11 times higher than that of thyroid tissue. And if you look at a standard situation like here, you have the autofluorescence of the parathyroid gland that is here much stronger than that of the thyroid gland, than muscle and fat at a given wavelength here. This is the ideal situation, but not all, it's not as high in every patient. So in some patients, the difference of intensity between thyroid and parathyroid gland is not as high, but in most of the patients, it is at least 2 times higher than as compared to the thyroid gland. So here you see the summary of the 256 parathyroid analyzed. There is a great interest in this topic. As you can see, there is a growing number of publications on this topic. This is until 2019, but it's still growing with a lot of paper that you can read if you want to see some review articles. You can see this one. I think it's pretty good. We also published one pretty recently. And there are basically 2 types of material that are able to detect parathyroid autofluorescence. One is a probe-based system, so you have a probe with which you should touch the parathyroid gland, and it's analyzed with fluorescence here. And the system gives you a tone when the intensity of the signal here is higher than the baseline that you have defined touching the thyroid at the beginning. This is the PTI, and to my knowledge, it is not approved in the European Union, so nobody has tried it in Europe, but it's used in the US. And the other system that is approved is an image-based system, and the one that is approved by the FDA is the FluoBeam. So you have a handheld camera, and then you make an image, and in the image you see this on the screen, and sometimes you see higher spot of more autofluorescence. This is the only one that is FDA approved for the image-based system, but there are other systems that can use autofluorescence, like the PDE from Hamamatsu, for instance. So the main difference is that with a probe-based system, you touch the tissue directly. With the image-based system, you have a camera here, but you should look on the screen. They have both advantages and disadvantages, but one main and important information is that autofluorescence system cannot tell you anything about the viability and the function of the parathyroid gland. It only tells you that it is parathyroid tissue, but parathyroid tissue are autofluorescent even if they are formalin fixed, if they are frozen, if they are heated. So these autofluorescent properties stays a long time even after excision of the parathyroid gland. So here you have an example. This is a thyroid lobe that is retracted medially, and you see that the thyroid is a little bit autofluorescent, but you see these two spots here are the superior and inferior parathyroid gland. Another example here, where you again have the right thyroid lobe that is medialized, and you see the upper parathyroid and the inferior parathyroid gland here. You also see that you have other things that are autofluorescent, like here the vicryl suture to retract the upper flap, the skin flap. Another example here, so the thyroid lobe is again medially retracted here in Babcock clamp. The vicryl suture is here, and you see this autofluorescent spot here behind the upper pole of the thyroid lobe, which corresponds to the upper parathyroid gland. It is more autofluorescent than the surrounding thyroid. Sometimes you see those autofluorescent spots on the resected specimen. Here you see a diving goiter with a deep nodule that is still autofluorescent, but you see this autofluorescent spot. Of course, it's a little too late to keep it inside with the vessels, but it's not too late before sending it to the pathologist. It's probably better to reimplant it rather than to send it to the pathologist. And as you can see also on this thyroid specimen, you see that the autofluorescence of the thyroid is different from one nodule to the other. So these autofluorescent properties can help you avoid sending too many parathyroid glands to the pathologist after resection. What about primary hyperparathyroidism? What we have shown here, you have again a left thyroid lobe here that is retracted, the inferior normal parathyroid gland that is highly autofluorescent, and you will see this patient had a primary HPT with a superior parathyroid adenoma, which is a little bit autofluorescent, but much less than the normal parathyroid gland. So this is one example, but we have demonstrated this in many different patients. So the autofluorescence of parathyroid gland is less intense in diseased parathyroid glands. So in adenoma, for instance, here the adenoma, here the normal inferior parathyroid gland. The autofluorescence is less intense in diseased parathyroid gland as compared to a normal parathyroid gland. And we studied this on this, for instance, adenomas. In many different adenomas, you can see that it is a little bit heterogeneous. And in some adenoma, you can see a white spot on the adenoma, here, for instance. And when you cut this, it stays white, as you can see here. We call this the cap Here you see it's autofluorescent, more autofluorescent in this part than in the adenoma part. And when we studied this and compared the more autofluorescent part with the pathology, we saw that the more autofluorescent part corresponded to a rim of normal parathyroid gland as compared to the less autofluorescent part that corresponded to the adenoma. So for autofluorescence can help the surgeon identify parathyroid glands in real time. In most of the studies, autofluorescence helped detect parathyroid gland earlier than with the naked eyes, therefore helping to protect them during thyroid dissection. In most of the studies, the authors found more parathyroid gland with the help of autofluorescence rather than with naked eyes only. And it decreased the number of parathyroid glands that go unnoticed to the pathologist with a thyroid specimen. Whether it could help preserve them in situ or whether it could help auto-transplant them is not quite clear, but it helps them avoid to send them to the pathologist. This is clear. Whether it can help distinguish healthy parathyroid glands from diseased parathyroid glands is a matter of debate or an open question, and it does not help to predict the parathyroid gland viability. So ICG angiography helps for the second part. ICG is a dye that stays in the vessels. When you inject it into a vein, it will stay in the bloodstream. It's bound to albumin and other proteins. It's extracted in the liver. Then if you have an excitatory light, it will re-emit an emission light from ICG. And what is the use? As you know, to protect the parathyroid gland, you not only need to protect the parathyroid gland themselves, but also their tiny vessels. And as you can see, often it's like here you have a left thyroid lobe here, the recurrent laryngeal nerve is here, and you can see this upper parathyroid gland is here. You can keep it easily in the patient if you do a total thyroidectomy, but you can also very easily damage its tiny vessels. And it's often the case. Here, right thyroid lobe here, that is an anatomical preparation. Here it's medially retracted. The recurrent laryngeal nerve is here. Inferior thyroid artery is here. And you see the upper parathyroid gland is here. The inferior parathyroid gland is here. Very easy to keep them inside, but very easy to damage their vessels. So you should take special measures to protect the vessel of this parathyroid gland. And our studies were mostly based on these techniques, ICG angiography. What we did the total thyroidectomy and then at the end injected ICG and looked at the parathyroid gland, whether they were well vascularized, like here. You see this is a superior parathyroid gland here. When you inject ICG, it gets very white. So it's very well vascularized. We called it ICG2, so well vascularized. Sometimes it was not the case. So here you have an inferior parathyroid gland here. We made a small incision. We see no active bleeding. It stays black, no color from the ICG. So we called it ICG0, not well vascularized or not vascularized at all. And we gave a score of 1 for everything that was in between, a little bit gray, not completely dark, but not really white as the vessels. So with this, we could demonstrate that one well-perfused parathyroid gland was sufficient to avoid hypoparathyroidism on postoperative day 1. So the measurement of PTH level were always normal in those 150 patients that had at least one well-perfused parathyroid gland. And in those patients, we could avoid measuring calcium and PTH on postoperatively, which sound trivial, but still everyone in the world makes at least one dosage of calcium and or PTH postoperatively. So we could safely send them home without any trouble in those patients who had at least one well-perfused parathyroid gland. Of course, the main limitation of our study was that we did not identify all 4 parathyroid glands in most of the patients, which is our standard way of doing thyroidectomy. And in fact, we identified 4 parathyroid glands in only 1/4 of the patients. And of course, if you cannot evaluate all 4 parathyroid glands, you don't know what is the perfusion and function status of the non-evaluated parathyroid gland. In short, our studies showed that we could predict very well the absence of hypoparathyroidism if we had at least one well-perfused parathyroid gland, but we could not predict well the presence and occurrence of hypoparathyroidism, mainly because we did not evaluate all 4 parathyroid glands in all patients. There are many studies on this topic again, and this is a current review study that is very interesting and coming from your colleagues, published very recently. At least 8, in this study, 18 papers included, but there are at least 4 more that just came out at the end of last year and this year. So just a few videos example here. You have one parathyroid gland. You see we inject ICG. It's coming in the carotid artery here, and then in the parathyroid gland. So you see that this parathyroid gland will function, and the patient will not develop hypoparathyroidism postoperatively. Another example here, again, a parathyroid gland that is well preserved. You see this with the pinpoint camera. You see that it is very well vascularized and stays very white, well perfused. This is a counter example. So one parathyroid that looks visually pretty good, but after ICG injection, it stays dark and it is not well vascularized. So at the beginning, we did not believe these things and these results. So we made a small incision, and you can see that there is no active bleeding in those parathyroid glands. Whether you have to re-implant them or whether you have to keep them inside, it's still a matter of debate. And for us, it depends on the local situation, whether we have other well-vascularized parathyroid glands or not. So we do not re-implant all of them, these non-well-vascularized parathyroid glands, but it's a decision we can make perioperatively. Here's the combination of both. You've seen thyroid lobe has been resected. Here you have seen with the autofluorescence, I show it again here, this autofluorescence of the 2 parathyroid glands here. And at the end, so now we inject ICG with the same system. This is the fluo beam now. And you can see that these both parathyroid glands are well vascularized, and this patient will not develop hypoparathyroidism. Another example here. This is the autofluorescence, so nothing has been injected now. It's the autofluorescence of the parathyroid gland here. The thyroid lobe has been resected. And now we inject ICG, and you see that this parathyroid gland is very well vascularized. You even see its tiny vessels here. So this one has been preserved. Another example here, this parathyroid is very well autofluorescent. So you see and you think you have preserved it very well. Now you inject the ICG. You see it's coming in the artery, in the carotid artery, in inferior thyroid artery here, and you see that the parathyroid gland stays completely black. It is not well vascularized or not vascularized at all. So now it's your decision to take whether you make a small incision, whether you keep it inside, or whether you re-implant it. But you know that it is not well vascularized. These techniques have helped us decrease our rate of hypoparathyroidism on postoperative day 1. So we had about 13% of non-measurable level of PTH on postoperative day 1 in 2012, and now we reduced this rate progressively, and we are at about 2 to 3% of hypoparathyroidism on postoperative day 1, defined as a low level of PTH. The PTH level is slightly higher currently with the use of this technique. And it's not only these techniques that helped us, but they helped us understand when the parathyroid were endangered. And so we take special measures and try to keep them more hardly than we did before. So we changed a little bit our surgical technique to help preserve those parathyroid glands when the vessels run really along the thyroid gland, for instance. We can also use ICG angiography to make sure that parathyroid remnants are viable during subtotal parathyroidectomy. Here, for instance, it's a patient with a secondary HPT in whom we do a subtotal parathyroidectomy. So here you see the thyroid lobe is retracted. We prepared 2 remnants. Of course, at the end, we will only keep 1, but just to make sure that we have at least 1 that is well vascularized. And you can see here that those 2 can be chosen, any one of them, because they are both well vascularized. So we can then cut this part of the parathyroid gland and remove all three others. And we will have a functioning remnant producing PTH. Of course, it does not avoid hypocalcemia, because in those patients, as you know, the hungry bone syndrome will be pretty tough. So even if you have measurable level of PTH, which we can demonstrate with ICG angiography, some patients will develop hypocalcemia because of hungry bone syndrome. There are, of course, some limitations for autofluorescence. There are some false positives. You have seen the vicryl suture. You have seen some thyroid nodule. Brown fat sometimes is also autofluorescent. Colloid nodule is autofluorescent. Sometimes metastatic lymph nodes. So if you do a central neck dissection, if you are not sure about the nature of your tissue, whether lymph node or parathyroid gland, you still should do a perioperative anatomical examination extemporaneous. The signal of autofluorescence, it's not standardized. It's not like ICG. So the intensity between parathyroid gland and thyroid is different from one patient to the other because of the intensity of the signal of the autofluorescence of the parathyroid gland, but also because of the intensity of the signal of the thyroid. For instance, thyroiditis have more autofluorescence than normal thyroid tissue. Autofluorescence cannot be used after ICG injection. So if you have injected once ICG to check for the vessels, for instance, on the first side, you cannot use autofluorescence on the second side because there will be too much remaining autofluorescence, or not auto, but there will be too much remaining fluorescence from the ICG that you cannot use autofluorescence anymore. For ICG angiography, some limitation, I just mentioned it to you. The correlation with postoperative PTH level is difficult because the PTH level is, of course, the result of the PTH production by all 4 parathyroid glands. And if you did not evaluate all 4 parathyroid glands with ICG, it's difficult to make a good correlation. It's not like for the nerve, for instance, you have a good correlation between your neuromonitoring because you know which side you had a problem or not, and you can do your laryngoscopy and you know which side is functioning or not. It's different from the parathyroid gland, and it's probably one of the current limitations because it's difficult to demonstrate a clear correlation between ICG scores, for instance, or fluorescence scores and PTH levels. And currently, no system gives numerical scale, so you only have a gray scale, which is visually very good, but it's not very good scientifically to compare between groups. And it's probably one of the reasons why some groups describe less encouraging results. So some people had some hypoparathyroidism on postoperative day 1 with a parathyroid gland that they described as well vascularized, but if you look at their pictures, probably they were not as well vascularized as we hoped or as we have been describing. In conclusion, autofluorescence can help detect parathyroid gland. ICG angiography can help protect parathyroid glands and their vessels during dissection and predict the absence of hypoparathyroidism. I thank you for your attention. I'm happy to answer your questions in black and white or in green.
Thank you, Professor Triponez. It was really outstanding as everything. And I will ask my co-chair, Dr. Christoforidis, to present the next speaker. Christos.